morning. At the outset, let me thank Dr. Manigandan and Dr. Kiran for this good opportunity. Uh, Respected teachers, senior colleagues and friends. So, how to pick up high-risk patients among acute coronary syndrome. So, sometimes you may be dealing with low-risk patients like this. From there, my task is to find out how you will pick up some of those patients who are high risk. So, risk stratification, it's an integral part of the management of acute coronary syndrome. So, we have several methods to find out which patient is more riskier to keep, whom to refer, or whom we can manage medically. To find out, we need proper risk stratification. Current guidelines advise TIMI risk score or GRACE risk score to assess the in-hospital and post-discharge risk. That's because if you apply this risk score, you can find out those patients who will respond to a various intensive treatment modalities and significantly influence therapeutic decision making. The most accepted, from an academic point of view, the most accepted one is GRACE risk score. You can see multiple parameters are there. Using that, you will do risk scoring. In hospital, risk scoring can be done. 6-month risk scoring can be done. I'm not going to the details. Just to bring to your attention what are the parameters which we will see for this, like Philip class. The higher the Philip class, you give more points. Systolic blood pressure. The lower the blood pressure, you get higher points, as you can see here. And if the BP is better BP is good prognosis. Heart rate. If the heart rate is more, you give more points. Like that, if the age advances, you give more points. Creatinine clearance. Better the creatinine clearance, lesser would be the point. Worse the creatinine clearance, more would be. Then finally, you will add all these points together. And you can see on the extreme right, if the point is more than 250, you have an in-hospital mortality more than 50%. On this side, if the score is less than 100, your mortality is less than 1%. But it's interesting, from the academic point of view, it's very good, but it's very difficult to apply in clinical practice. A better TIMI scoring would be easier. See, here you need to learn only 7 points, and for each parameters, you will give 1 point each. Like if age more than 65, you give 1. More than 3 risk factors for coronary artery disease, 1 point. If the patient has used aspirin in the last 7 days, 1 point. Known coronary artery disease or previously angiogram has shown insignificant coronary artery disease less than 50%. More than 1 episode of rest angina in the last 24 hours, ST segment deviation and elevated cardiac markers like troponin. For each parameters, you will give 1 point. When you add these points, the more the points, you have more mortality. As you can see here, if it's 0 to 1, your all-cause mortality, new or recurrent MI or severe recurrent ischemia is 4 to 4.7%, whereas on the other end, 6 to 7 points, your event rate is more than 40%. Similarly, you have TIMI scoring risk for STEMI patients also. Difficult to practice, but in STEMI, most of the time we may not be going for scoring system, because for all STEMIs, the purpose is, if the patient is having high risk, you will accelerate the patient's management. Patient needs more intensive management as early as possible. So if you look this flow chart, when the patient comes to you after the first medical contact, you made a diagnosis of non-ST elevation acute coronary syndrome. You look at the right side. First, you have to risk stratify the patient. Risk stratify the patient. At the end of that, you get patients of high risk, very high risk patient, and low risk patient. If the patient is of high risk, you refer them, and the patient need to refer them to a PCI center as early as possible. An immediate invasive strategy in less than 2 hours should be advocated. If the patient is having high risk, then refer the patient on the same day and take the patient for invasive management in less than 24 hours. In low risk, you have time. You can manage medically, or later stabilizing the patient, then take up the patient. These are the very high risk parameters. If the patient is having hemodynamic instability, patient is in heart failure or shock, cardiogenic shock, recurrent or refractory chest pain despite medical management, life-threatening arrhythmias, recurrent cardiac arrest, VT, ventricular fibrillation, mechanical complications of myocardial infarction, acute MR, PSR, like that. Acute heart failure clearly related to non-ST elevation ACS and ST segment depression more than 1 mm in more than 6 leads plus ST segment elevation in AVR or V1. If these parameters are there, any one of these parameters are there, the patient is having very high risk. And if these are not there in established non-ST elevation MI diagnosis, those patients who are having troponin positive or high biomarkers, dynamic new or presumably new STT changes, resuscitated cardiac arrest, gray score more than 140, in these type of patients, you categorize them as high risk. So if the patient is very high risk, you refer them to a PCI center, and the patient has to get invasive management as early as possible in preferably less than 2 hours. If the patient is high risk, you refer them within 24 hours, the patient has to be taken up for angiogram followed by intervention if possible. If none of these parameters are there, patient is low risk, you start medical management and manage the patient accordingly. This patient, as you can see in this ECG, there are ST depressions in multiple leads. More than 5 leads you are getting ST depressions, and these ST depressions are downsloping. You can see 2 to 3 mm ST depressions downsloping in multiple leads, in V3 to V6, lead 2, 3, AVF, L1, and you can see ST elevations in AVR and V1. This patient is having global ischemia. ST elevation in AVR not specific to, initially we thought it's specific to left main, but it need not be. It may be occur, these patients are having more severe coronary artery disease, non-ST elevation type. It can usually be, we say it's a sign of severe triple vessel disease, but sometimes you can get this in proximal LAD or left main disease. And diffuse subendocardial ischemia, example following resuscitation after a cardiac arrest. So if you are getting patient like this patient is having more severe type of coronary artery disease, either left main or proximal LAD or three vessel disease. So it's better to refer the patient early. Look at this. In this type of patient, here also you are getting ST elevation in AVR, but in other leads, multiple leads you are getting ST depressions, no ST elevation in V1. So here it is more suggestive of a left main disease rather than multivessel. If you are getting ST elevation in AVR, if AVR ST elevation without ST elevation in V1, it's a predictor of acute left main stenosis and can be a marker of severe diffuse coronary artery disease in acute non-ST elevation MI. So ST depression in multiple leads, more than 6 leads with ST elevation AVR and V1. Or here in this lead, you are getting ST elevation in AVR without much ST elevation in V1. It's more suggestive of left. This particular ECG, you can see there is upsloping J-point depression in V2 and V3. This is De Winter sign. With hyperacute T, so you can see poor progression of R wave in V1 to V3. There is J-point is depressed and there is upsloping ST with tall T waves, tall symmetrical T waves. It's De Winter sign. 1 to 3 mm upsloping ST depression at the J point in leads V1 to V6, followed by tall positive symmetrical T waves. So QRS usually not widened, or it's slightly widened. And you can see in some cases a loss of precordial R wave progression, but it's not a must. In most 1 to 2 mm ST elevation in AVR. As you can see here, can be some 1 or 2 mm ST elevation in AVR, but it's not a must. This is De Winter sign. 1 to 2 mm. This signifies acute occlusion of proximal left anterior descending. Possibly it's a new indication of primary PCI. So it has not come as a guideline, but it was first described in 2008. But if you are getting patients like this, you have to be more careful. There could be a proximal LAD disease. Patient can develop serious type of problems. You have to be very careful. Patient should be in the CCU and take the patient for invasive management as early as possible. And in this ECG, you can see the R-wave progression is good, but more than 5 mm symmetrical T-wave inversions in anterior leads from V2 to V6, it's there. No other significant STT changes anywhere. This patient, at the time of admission, there is no chest pain, but it's called Welland sign. The importance is it's specific for significant proximal left anterior descending lesions. Even when there is no active chest pain, usually at the time of admission, there won't be any active chest pain. Patient gives history of typical chest pain. At the time of admission, patient may be asymptomatic, but you get ECG like this. And this is not a STEMI equivalent, but predicts the impending myocardial infarction in the next few days or weeks. Number need to treat with revascularization to prevent an MI is only 2. So yeah, if you get an ECG like this, even though the patient is not having active chest pain at the time of admission, these patients are likely to develop a STEMI or a recurrent chest pain in the near future. 1 in 2 patients can develop that. So number need to treat with revascularization to prevent a myocardial infarction is only 2. So this Welland sign. Then this signifies a proximal LAD lesion. Then I'll be shortly discussing some STEMI scenario also. This is uncomplicated inferior wall MI. Okay, time constraints are there. But along with inferior wall MI, if you are getting changes like this, if you look at this ECG, you can see ST elevations happening in V5, V6. If you look at V1 and V2, you can see the R waves are getting, in V2, R wave is relatively tall. There is ST depression with upright T. So this is inferior, along with inferior wall MI, there is evidence of posterior wall and lateral wall myocardial infarction. So these type of patients, even though it's not a simple inferior wall MI, these patients are more likely to have complications. Look at this. This is an inferior, STEMI inferior wall. It's very evident, 2-3 AVF, there is ST elevation. Along with that, you can see ST elevation in V1 and V2. This is inferior wall with right ventricular myocardial infarction. In this particular patient, you can see there is ST elevation in inferior wall. Along with that, if you look at 2 things are there. One thing, the patient has got AV block. It's bradycardia. One more thing, if you look in V3, beyond V3, then in V5 and V6, you can get ST depression, downsloping ST depression. This is STEMI inferior wall, 8 degree AV block. And if you are getting ST depression extending beyond, see in V1 to V4, you can get ST depressions in STEMI. That could be part of reciprocal changes, but it's extending beyond that, it could be a sign of multivessel disease. If you look at this particular ECG, along with, this is a patient with STEMI inferior wall. Along with that, if you look at anterior leads, you can see R wave progression is not good. V1 to V4, V1 to V5, there is no R wave. So this patient, it's an old anterior wall MI and now coming with STEMI inferior wall. The prognosis is bad. So how to find out high-risk STEMI inferior wall associated, STEMI inferior wall associated lateral wall myocardial infarction ST elevation, posterior wall MI or RVMI, they are having high risk, AV blocks, ischemia at a distance, presence of old anterior wall MI, as we can see in this. So these patients are having high risk. If you look at anterior wall, these are STEMI patients, STEMI anterior wall patients. You can see ST elevations in V1 to V4. Along with that, you can see ST depressions in inferior leads 2-3 AVF. ST elevation V1, ST elevation AVR. So here, it's an occlusion proximal to S1 and D1. These patients are likely to have severe left ventricular dysfunction and they can develop cardiogenic shock also. High risk patients. If you look at this particular ECG, again, this is ST elevation MI, and along with that, you can see RBBB, QRBBB. In the along with RBBB, there is ST elevation in anterior leads, V1, V2, up to V4. So when you're getting a RBBB, QRBBB, new development of that, along with ST elevation in anterior wall, that signifies this could be a proximal LAD disease. These patients are likely to develop severe left ventricular dysfunction, and cardiogenic shock. You have to be careful. High risk patient. So in STEMI anterior wall, these are the groups where you get high risk ECG patterns, new right bundle branch block. Here it could be an LAD lesion proximal to S1. Infra-ECN AV blocks. ST elevation in AVR, that signifies left main or LAD lesion proximal to S1. ST elevation in V1 if it's more than 2.5 millimeter, or ST depression in V5 more than ST depression in V5 along with ST elevation in V1 to V4. All these signifies occlusion of left anterior descending proximal to S1. You can see here. LAD lesion, this is a QRBBB with ST elevation, proximal LAD is disease. Thank you.
Thank you for that. Now, that's a very important correlation with the ECG and the other high-risk factors, and you have impressed all of us about the importance of early referral or early intervention. Thank you.